A very good evening to all of you. Welcome to this recall session of INI-CET May 2022 Pediatric Recall Questions. I have tried to get some of the questions. Students have been able to recall some of the questions which are pediatric questions. I could get 8 out of the pediatric questions. There were some more, but they were partly discussed as pediatric surgery questions and some of them as pediatric orthopedic questions. So I could get around 8 pediatric questions. There are some options which might be missing. That is because some of them have been partly recalled by the students. As and when you have more definitive answer of the exact type of questions, you can send it to me and I would be able to discuss those questions at a later date or tell you the answers according to me, which according to me would be the best answer for that question. So let us start with the first question that I could get from the students. This is a question which we have discussed in our class also. In my regular batch classes also I've discussed this, and my foundation batch classes I've discussed this. And this question is, identify the X-linked dominant condition among these. So I have very clearly discussed this in the chapter of microcephaly in my classes. When I was teaching for my pediatric app, I discussed about this. I've been teaching this in my classes also. Microcephaly can have many causes, and one of the possible causes of microcephaly in children is Rett syndrome. And Rett syndrome is primarily an X-linked dominant disorder. So the X-linked dominant disorder among these conditions is the Rett syndrome. Rett syndrome is a neurodevelopmental disorder which develops in children. It is known to affect primarily the females. So primarily it is the females who are affected. Since it's categorized as a neurodevelopmental disorder, the disorder is associated with developmental regression. That means most of these children till the age of around 18 months to 2 years are growing normally, are acquiring those milestones which normally develop in children according to their age. But from around 18 months to 2 years of age, these children start losing these milestones. That is why we categorize this as a neurodevelopmental regressive disorder. You should not differentiate, you should not confuse it with a cerebral palsy. Many of these disorders associated with cerebral palsies are disorders in which there is delay in acquiring the milestones. But then there are a group of disorders in which there is regression of already acquired milestones. Those group of disorders are known as neurodevelopmental regressive disorders. And one of the examples of a neurodevelopmental regressive disorder is the Rett syndrome. So till the age, as I told you, about 18 months to 2 years of age, these children are growing normally, after which the child starts losing many of those acquired milestones, including these children have loss of purposeful hand movements, and these purposeful hand movements which are lost are replaced by involuntary stereotypical hand wringing movements. Then there is even loss of speech. So most of the acquired speech that the child has acquired during this time can also be lost during this time. Many of these children also have a very clumsy gait. These children also have microcephaly, so their head does not grow as per the norms, and that results in a child having a small head. And this is a very important cause of intellectual disability in girls. One of the most common causes of intellectual disability, which we used to call in the past as mental retardation, one of the most important causes of intellectual disability in girls is Rett syndrome. This is as against the one of the most common causes of intellectual disability or mental retardation in boys, such as Fragile X syndrome. Rett syndrome is the most common cause of, or one of the most common causes of intellectual disability or mental retardation in girls. In fact, a combination of a microcephaly, loss of previously acquired milestones. So there is a state when the child is developing milestones normally, followed by a state where there is a state of regression of the milestones, and then a static state. So any child who follows this type of a state, normal development of milestones till around 18 months to 2 years, followed by regression, loss of the already acquired milestones, followed by a stabilization state. But by this time, the child has already lost most of his acquired activities, such as loss of purposeful hand movements, loss of acquired speech. Their head does not grow normally, resulting in a small head of microcephaly, and they also have intellectual disabilities. Plus, they have a number of other problems, including metabolic problems. They have cardiac problems. Prolonged QT syndrome is one of the very important complications which can lead to arrhythmias and can be often fatal in these children. So prolonged QT syndrome is one of the cardiac disorders that can develop in these children. These children also have autonomic aberrations, so they may have hypoventilation, hyperventilation, breath holding, different type of behavioral problems these girls may be having. So although there is no relatively a single treatment or a cure of this disorder, most of the management of Rett syndrome primarily is based upon treatment of these problems that the child is having, treatment of the behavioral problems. Many of these children, girls, may have seizures, so the treatment of seizures. Many of these girls may have sleep difficulties, so treatment of the sleep difficulties. Cardiac problems, if they are there, you have to manage the cardiac problems. Many of these children have pathological fractures, so those type of fractures need to be treated. So basically what you're trying to do is treatment of the symptom presentation of these children. Otherwise, there is no cure of this disorder. So the typical example of a X-linked dominant disorder is Rett syndrome. I couldn't get the other options except for spinal muscle atrophy. Some students said spinal muscle atrophy was another option. And I've discussed spinal muscle atrophy in my app also. And spinal muscle atrophy is primarily a neuromuscular disorder. It's an autosomal recessive group of disorders. So spinal muscle atrophies are not X-linked dominant disorders. They are primarily autosomal recessive group of disorders where the child presents with progressive muscle weakness, hypotonias. So many of these children with spinal muscle atrophies often present in young life with a floppy infant presentation. And in my app presentation, I have discussed that spinal muscle atrophies may be of 4 types, including type 0, which is a very severe type, often associated with intrauterine deaths, also called as spinal muscle atrophy congenita. Then you often have a type where the child presents with severe muscle weakness in the first 6 months of life, that is spinal muscle atrophy type 1, also called as Wernicke-Hoffmann's disease. Then there is a type which presents with presentation between 6 months to 18 months, which is known as the Dubowitz disease, spinal muscle atrophy type 2. Kugelberg-Villander disease, which is spinal muscle atrophy type 3, which has a later presentation. So all of these disorders associated with progressive muscle weakness, spinal muscle atrophies, they are autosomal recessive group of disorders. So they are not X-linked dominant. Regarding Asperger's syndrome, if it was another option, is again a neurodevelopmental disorder. But although there is a hereditary component related to, a genetic component related to Asperger's syndrome, Asperger's syndrome is actually not primarily known to have a familial pattern of inheritance. It has a genetic component to it, but it does not present with a familial pattern of inheritance. So Asperger's syndrome, these children have loss of communication or interaction skills, and it primarily is a disorder which is put under an autism spectrum disorder. The psychiatry faculties would be able to outline this disorder much better than me. But overall, if the question is which is the X-linked disorder, X-linked dominant disorder. Among these options, I did not have the third or fourth option available. But Rett syndrome at the outset is a very clear option, which is associated with X-linked dominant presentation. Then question number 2 again was a question which we have discussed in a class, and those who have attended the classes, those who have gone through our app, would have been easily been able to answer this question on neonatal resuscitation. The question was, which is the best way to assess the response to ventilation in neonatal resuscitation? The chest rise, the respiratory rate, the heart rate, or the color change? Now we have discussed about neonatal resuscitation in my app also, and this is the screenshot from my app where I very clearly outlined that when a child is started on positive pressure ventilation, it's the heart rate which helps you decide whether you should discontinue the ventilation because the child is improving, or you should move on to the next step, which is chest compression. So the ideal way of starting a positive pressure ventilation, which is the recommended indication for starting the positive pressure ventilation, is that any newborn who continues to be in a state of apnea or has a persistent bradycardia, heart rate less than 100, despite giving tactile stimulation at 60 seconds of birth, this child should be immediately started on a positive pressure ventilation. Now here one of the things that I mentioned was heart rate less than 100. So you can very easily understand that heart rate evaluation is one of the best ways to evaluate the success of each step of neonatal resuscitation. So at each step of neonatal resuscitation, you will not be seeing the respiratory rate, you will not be seeing the color change, you will be focusing on the heart rate. And up until the child's heart rate has improved to more than 100, till the time it is less than 100, we call it as a neonatal bradycardia. So up until the heart rate of the newborn has come to over 100, the neonatal resuscitation step should be continued. So if you have started a positive pressure ventilation, such as ambu bag with mask, and you are giving positive pressure ventilations for around 15 seconds, and the child does not seem to be improving, and how will you know the child does not seem to be improving? Evaluating the heart rate. So the child's heart rate keeps on falling, dropping, which is a very clear indication that the child continues to be in a state of hypoxia. So I told you, in those cases where the child is not improving on positive pressure ventilation, after 15 seconds, you can do corrective steps which are given by the mnemonic MR SOPA, which includes mask readjustment, repositioning the babies, suctioning the secretions, which is likely because the secretions are blocking the airways. That is why, despite giving a positive pressure ventilation, the child is not improving. Then opening up out the mouth further of the child, then increasing the pressure of ventilation, and then alternative airways such as intubation. Now, despite intubations and ventilations, if the child is still not improving, this is very clearly an indication to move on to the next step, and that is chest compression. And what is that parameter by which you will know that the child is not improving? Heart rate evaluation. So at each step, even in my app, I have mentioned about the importance of heart rate. Each step, be it starting of positive pressure ventilation, be it starting of chest compression, be it introduction of epinephrine, at each step, you have to evaluate the success of that step by evaluating the heart rate of the child. So the best way to assess the response to ventilation, according to me, is clearly heart rate evaluation. I think, if I'm not wrong, this question has been there in the past also, and it's a very important question. Many students confuse it with color change. They believe that color change after initiating ventilation or chest compression would be the best way to guide whether the child is improving or not. This is wrong. The color change, in fact, can be many times misleading also, because the acrocyanosis which is extremities blue when the child pink, can sometimes be a normal phenomena or a partially normal phenomena in a child also. So what is important is to always evaluate the neonatal resuscitation steps using heart rate as the primary parameter. And although 3-lead ECG is primarily recommended in most neonatal resuscitation guidelines, but because of logistic issues, that way of heart rate evaluation is very difficult in Indian setups. So even using a stethoscope, a heart rate evaluation should be a good enough method to evaluate whether the child is responding to each and successive neonatal resuscitation steps or not. So what is the best way to assess the response to ventilation in neonatal resuscitation? It is heart rate. And I've discussed about this neonatal resuscitation in my classes also. I've discussed it in the app also, and it's very clearly mentioned that heart rate which is not improving and falling to less than 60 is an indication now to start chest compression. The third question, which actually speaking, I don't know if that question was mentioned related to pediatric age group or not, and might have been discussed in the biochemistry class by your biochemistry faculties. If it has been discussed, very good. If it has not been discussed, just a word about this. The question, why I'm taking this question here is because it's a commonly diagnosed metabolic disorder in children. The question was asked, and we have discussed about this metabolic disorder in our app content also. The question was, which amino acid need not be restricted in the diet in a child with maple syrup urine disease? And we have discussed about maple syrup urine disease in a app under metabolic disorder section. Maple syrup urine disease is a metabolic disorder. First, it's an autosomal recessive group of disorder, and it's primarily associated with deficiency of the branch chain keto acid dehydrogenase, which results in accumulation of the branch chain amino acids. So these branch chain amino acids such as the leucine, isoleucine and the valine, they start accumulating in the blood. So these branch chain amino acids, they start accumulating in the blood, which is actually the main problem that is seen in these children. And one of the most dangerous metabolite, accumulation of which is detrimental, particularly to the nervous system in the child, is leucine. Leucine is a neurotoxic metabolite. So when this metabolite keeps on accumulating, it can lead to various problems in these children starting very early in life. So these children have feeding difficulties, they have neurodevelopmental delays, they often have seizures, they have failure to thrive. So that's a primary presentation of a maple syrup urine disease. There is this maple syrup odor which first appears in the cerumen in the first 12 hours, and then it appears subsequently in the urine. And because there is accumulation of the branch chain amino acids, naturally the branch chain amino acids should not be given in the diet. So which branch chain amino acids should not be given in the diet? Leucine, isoleucine, valine. Because they are accumulating, they should not be given in the diet. So methionine need not be restricted in these children. In fact, in my app, the next condition or the next metabolic disorder that I talked about after maple syrup urine disease was the disease in which methionine and homocysteine accumulates, which is homocystinuria. Now there you have to be more restrictive of methionine, homocystinuria, because homocystinuria is a disorder which is associated with deficiency of the enzyme cystathione beta synthase. So when there is deficiency of the enzyme cystathione beta synthase, cystathione is not forming from homocysteine. So homocysteine is accumulating, and this homocysteine can convert into methionine also. So not only homocysteine but methionine also accumulates in the blood and in the urine. So that's the reason why methionine should not be given in high concentrations in children who have homocystinuria, but not in maple syrup urine disease. Maple syrup urine disease is problems of the branch chain amino acids. Leucine, isoleucine, valine, they are accumulating. So there is no point of withholding methionine in the diet in these children. Coming to question number 4. Now question number 4 is a question that was asked on human papilloma virus vaccines that needs to be given in girls between 9 to 14 years of age as per the WHO SAGE recommendations. Now again, in my app, in the vaccination section, immunization section, I've discussed about human papilloma virus vaccines in detail. Now these vaccines are very important as protection against human papilloma virus, which is one of the leading causes of cervical cancers in our country. There are 3 primary human papilloma virus vaccines which are available. One is the bivalent vaccine, the Cervarix, the quadrivalent vaccine, the Gardasil, and the more recently introduced, the nonavalent vaccine, Gardasil 9. The bivalent and the quadrivalent vaccines were licensed for use, I think, in India in 2008, while the nonavalent vaccine, which is the more recent vaccine, which has been licensed for use in 2018. And nonavalent human papilloma virus vaccine is the only human papilloma virus vaccine here in India, which has been approved for use in boys. Now, human papilloma virus, although it's one of the major causes of cervical cancers, but it's also known causes of malignancies of the anus and penis. So it can affect the boys as well. So you need to have protection for the boys as well. So while the bivalent and quadrivalent vaccines are approved or licensed for use for only girls, the nonavalent vaccine, which was recently licensed for use, is being used for all boys and for girls. So it's, I think, licensed for girls. The nonavalent vaccine is licensed for girls between 9 to 26 years of age, and it's licensed for boys between 9 to 15 years of age. Now just a few words about the WHO SAGE recommendations. Now this strategic advisory group on vaccination, the WHO's strategic advisory group on vaccination, the WHO SAGE group, recently came up with an updated recommendation. Now normally the human papilloma virus vaccine, which has been given in our schedule, the IAP schedule, Indian Academy of Pediatrics schedule, the schedule was 2 doses of the human papilloma virus vaccine 6 months apart are being recommended in all girls between 9 to 14 years of age. But in all girls who are more than equal to 15 years of age, or in all immunocompromised girls, children, 3 doses of the human papilloma virus vaccines are recommended, either given as a 0-1-6 month schedule for the bivalent vaccine or given as a 0-2-6 month schedule for the quadrivalent vaccine. So let us focus only on children who are between 9 to 14 years of age, because our question is focusing on 9 to 14 years of age. So ideally, between 9 to 14 years of age, 2 doses of human papilloma virus vaccines are recommended 6 months apart. So the best answer should be 2 months. However, with the aim or objective to increase the vaccinations and bring it to more target population, the WHO SAGE recently had recommended an update, and they suggested, as you can see here, that a single dose of the human papilloma virus vaccine, I think this was given, or this update came on the April 11th, 2022 or April 12, 2022. So it's a very recent recommendation where they suggested that a single dose of the human papilloma virus vaccine delivers solid protection against human papilloma virus and may be comparable to the 2-dose schedules. So what they've suggested is that a single dose schedule of human papilloma virus vaccine can be comparable to the 2-dose schedule. So what they have suggested is to update the dose schedules of human papilloma virus vaccine to either a 1 or 2 dose schedule for children between 9 to 14 years, girls between 9 to 14 years, a 1 or 2 dose schedule for young women between 15 to 20 years, and a 2-dose schedule with a 6-month interval for women older than 21 years. And for all immunocompromised girls, a 3-dose schedule is necessary. If at all 3 doses is not available, then at least 2 doses. But 3 doses otherwise is recommended for all immunocompromised children. Now the question is that if the WHO has recommended that a single dose or a 2-dose schedule is comparable, and what I understand is they have suggested an update of the current schedule. They have not updated the current schedule, they have suggested. And even in that suggestion, the primary suggestion is that a 1-dose or a 2-dose schedule is comparable, which means they want to reduce down the utilization of the human papilloma virus vaccines and make the available vaccines for a bigger target recipients. So basically what they want is that rather than using 2 doses, if 2 doses are comparable to 1 dose, then why not use 1 dose, and thereby you will be able to vaccinate more number of girls, and therefore you will be able to reach a bigger target recipient population. But first, since this is a suggested update, second, they have nowhere said that a 2-dose schedule is not useful and you should replace a 2-dose schedule with a 1-dose schedule. Therefore, according to me, the best answer for this should be a 2-dose schedule. Now, there have been students who have been asking me, so 1 dose is also given. But please see here, they have nowhere said that a 1-dose schedule should replace a 2-dose schedule. And the schedule that we have been following till now is a 2-dose schedule only, which is 6 months apart between 9 to 14 years of age. So the point of understanding is that while they do recommend an update of the schedule and suggest that a 1-dose schedule is comparable to a 2-dose schedule, they do not say that a 1-dose schedule should replace a 2-dose schedule. Therefore, according to me, what I understand is that the recommended dose of human papilloma virus vaccine in girls aged 9 to 14 years, as per WHO's age recommendations, can be a 1-dose schedule also and 2-dose schedule also. Again, I'm saying I do not exactly know the language of that question. So I'm going by what the student said. A slight different language to the question might change the answer also. But if we go according to this language of the question, a 1-dose schedule and a 2-dose schedules are comparable. But since a 2-dose schedule is being followed and has been found to be beneficial, and since a 1-dose schedule is suggested as an alternative but has not been suggested as a replacement for a 2-dose schedule, therefore according to me the best answer should be a 2-dose schedule. My answer may not concur with many others, but I still feel that according to me a 2-dose schedule answer should be the best. Although yes, you should know that the WHO in its recent 11th April 2022 recommendation has suggested that 1-dose schedule of human papilloma virus vaccine can be comparable to a 2-dose schedule in children between 9 to 14 years also and between 15 to 20 years also. Coming to the next question, which is question number 5. The question was on preterm milk. Now, the question was, which of the following is the best alternative to breast milk in preterm babies? See, there is actually speaking no alternative to breast milk, to be very frank. Breast milk is always the best recommended milk for all newborn babies, especially for preterm babies. But the point is, suppose a mother is not able to give her breast milk to a baby, then what should be the other available alternative? According to me, the other available alternative to a breast milk should always be another form of breast milk, which is a donor breast milk. It's very clear. See, breast milk of the mothers who deliver a preterm baby is different from a breast milk of a mother who delivers a term baby. And the reason is that during the later part of gestation, the fetus is known to take in amniotic fluid, which contains a lot of vitamins, lot of minerals, lot of proteins. That amniotic fluid, which has lot of proteins, vitamins and minerals, which are taken up by the fetus during the later part of its gestation in the intrauterine life, contributes to about 15 to 20% growth during that period. So any fetus who is delivered early, so the child is a preterm child, will not be getting that benefit of the later part of gestation growth, and that is the primary reason. That is the primary reason why the breast milk of mothers who deliver preterm babies is much higher in. So preterm babies, because of their requirements, the breast milk of the mothers who deliver preterm babies is much higher in the protein content, is much higher in the immunoglobulin content, is much higher in the calorie content, is much higher in the iron content, is much higher in the sodium content. So it is different from the breast milk of a mother who has delivered a term baby. So you are seeing there are differences between a breast milk of a mother who has given birth to a preterm baby and breast milk of a mother who has given birth to a term baby. The point I'm trying to emphasize is that the breast milk changes are just to cater to the needs of a preterm baby. And that's the reason why breast milk is always the best. There is only one problem here, and the problem is that donor breast milk may not always be coming from a mother who has delivered a preterm baby. Many of the mothers who provide this donor milk actually are the mothers who have given birth to term babies, have already given feeds to their babies. The babies have been weaned to top food, and now those mothers are expressing their milk and providing it as a donor milk. So the milk that is being expressed is actually a milk which is for a term baby, and that actually has differences from a milk of a preterm baby. But still, given the fact it's a breast milk, any day I would always say that the breast milk is always the best milk for preterm babies. So your choice should always be donor breast milk is the best milk for preterm babies. It has its downsides also, some problems also. For example, when you are giving donor breast milk, you are likely to many times increase the risk of transmission of infections, especially viruses like HIV, cytomegalovirus, hepatitis B. And that is why pasteurization of this donor breast milk is now being recommended. But that pasteurization has other problems. It actually is known to reduce down many bioactive compounds in the milk. But even then, a donor breast milk for a preterm baby is the best milk, especially because studies have clearly shown that when a donor breast milk is compared with a preterm formula milk, the risk of necrotizing enterocolitis can be significantly reduced by using the donor breast milk compared to a preterm milk. So a donor breast milk is always better compared to a preterm formula. Although a preterm formula also contains many of those essential ingredients which are required for a preterm, like calcium, like iron. But please try to understand there is no replacement for actually a breast milk. So ideally the mother feeds the baby herself, and if it is not possible, then at least a donor breast milk would be the best way of feeding the baby. So what is the best milk that the mother should give to her preterm baby? It's a donor breast milk. If that is not feasible, then go to a preterm formula milk, but never cow's milk. Cow's milk is actually the last option that should be kept. Cow's milk is not recommended as such, particularly because of the very high protein content, the protein load of the cow's milk, which can actually have a very detrimental effect on the kidneys of the preterm child. So cow's milk actually is not recommended, at least as a first or a second line alternative. The first line alternative, the first line replacement feed should always be the donor breast milk, followed by, if that is not possible, followed by the preterm formula. And in case you are giving this express donor breast milk in a preterm baby who is less than 1.5 kgs, that means who is actually a low birth weight baby also, you need human milk fortifiers. These are special ingredients which need to be added from outside to increase the calorie content of the milk and to add essential ingredients, the vitamins, the minerals that these preterm babies will be requiring. So I hope I've answered this question according to me. Which of the following is the best alternative to breast milk? The best alternative to breast milk can only be a donor breast milk. Coming to question number 6. Now question number 6 says a 4-year-old child with a weight of 15 kgs, with a height of 100 centimeters and with a serum creatinine of 1 milligram per deciliter has a serum urea of 100 milligrams per deciliter. I'm not sure of the values, but this is the values that we got from the students. Calculate the closest approximate glomerular filtration rate in this child. Now, glomerular filtration normally starts in the fetus from about, I think, the 6th week of intrauterine life. And the glomerular filtration rate keeps on increasing till the kidney keeps on growing till, I think, around 18 to 20 years of age. And for evaluating the renal functions, glomerular filtration rate is very essential. Now, although there are many methods by which you can measure the glomerular filtration rate, I think the best method for measuring the pediatric glomerular filtration rate, so in pediatrics, the best method is always the bedside shots formula. Now this bedside shots formula says that the estimated GFR can be given by a formula which is 0.413, a constant, multiplied by the height of the child in centimeters upon the serum creatinine in milligrams per deciliter. So what you are actually seeing is that in this question, the weight of the child, the age of the child, the blood urea of the child, they actually carry no value. Either they are just to confuse you or they are just given as values to increase the length of the case. The only thing that you will be requiring for calculating the glomerular filtration rate will be the height of the child in centimeters and the serum creatinine in milligrams per deciliter. So if you calculate the eGFR by this method, 0.413 multiplied by the height in centimeters, which is given as 100 here, 100 centimeters is the height of the child, upon a serum creatinine which is 1 milligrams per deciliter. So the child's eGFR comes out to be 41 approximately, 41 ml per minute per 1.73 meter square body surface area. This is meter square body surface area. So 40 is what the GFR is coming out to be, and the closest answer therefore according to me should be C. So we are calculating the glomerular filtration rate based upon the child's serum creatinine and the child's height. No need to know the blood urea. Very recently, cystatin C is another variable that has been added along with serum creatinine to increase the efficiency or increase the accuracy of the estimation of GFR. Cystatin C has many advantages over creatine. For example, cystatin C is not secreted by the renal tubules. Then cystatin C is less affected by age, gender, muscle mass in comparison to creatine, which can be affected. So if you measure the glomerular filtration rate in children by utilizing both serum creatine and statin C, this can actually give you a better measure of the glomerular filtration rate compared to the use of serum creatine alone. But this is a bedside formula for measuring the glomerular filtration rate, which gives you a fairly accurate reading, and therefore the answer to our question here should be 40 ml per minute per 1.73 meter square body surface area. Answer here should be meter square body surface area. Now coming to question number 7. Now this question again is a question that we have discussed in our app also. We have discussed this question in our classes also. The question was indication of ACTH in children. Which type of seizures? We still do not know the fourth indication. I think the previous three indications A, B, C were West syndrome, Rolandic seizures and juvenile myoclonic seizures. So we have discussed about West syndrome or infantile spasms in my classes. West syndrome or infantile spasms typically occur in infants, and they are combination of, as I told you, epileptic spasms. They are combination of epileptic spasms along with developmental regression or psychomotor regression, along with a very characteristic EEG pattern. A very characteristic EEG pattern which is called as hypsarrhythmia. So a combination of epileptic spasms, developmental regression or psychomotor regression, and a characteristic EEG pattern with high amplitude spikes with a chaotic or a disorganized background rhythm, which is called as hypsarrhythmia. This is West syndrome or infantile spasms. It is believed that this was first identified by Dr. West in his own child, and since then this disorder is known as the West syndrome. The drug of choice for West syndrome is ACTH. So a 2-week course of ACTH, usually in 2 divided doses, followed then by decreasing doses over the next 2 weeks. This is the treatment of West syndrome or infantile spasms. In case infantile spasms or West syndrome are associated with tuberous sclerosis, then the drug of choice is vigabatrin. So in case you have West syndrome which is associated with tuberous sclerosis, then the drug of choice will be vigabatrin. Otherwise, the drug of choice for West syndrome and infantile spasms is always ACTH. Prednisolone or steroids have also been used in some cases as a third line alternative, but the best and the drug of choice is usually ACTH. Juvenile myoclonic epilepsies we have discussed again in our app also, in our classes also, and juvenile myoclonic epilepsies usually are known to occur in adolescents, and their drug of choice is usually valproate, sodium valproate. These are seizures that occur in the typical early morning hours. They are either a combination of absence epilepsies or myoclonic jerks or even generalized tonic-clonic epilepsies. But typically they occur in the early morning hours, and that too in adolescence. Juvenile myoclonic epilepsies have very good prognosis, may require lifelong treatment, but otherwise very good prognosis, and the drug of choice is valproate. Now, regarding Rolandic seizures, I have not discussed about Rolandic seizures in my classes. Although Rolandic seizures actually are against common types of epilepsy syndromes that are seen in children. So these Rolandic seizures, they actually are sometimes also called as benign epilepsies with centrotemporal spikes, and the name Rolandic epilepsies or Rolandic seizures comes from the fact that they originate from the Rolandic area of the brain. They originate from the Rolandic area of the brain. That is why their name is Rolandic epilepsies. Another thing that you might have noted here is the term benign. So most of these seizures are known to occur somewhere till around 1 to 12 years of age. By adolescence, most of these seizures stop. So they stop on their own. So do not require usually any treatment after 12 years of age, because most of these seizures, they usually stop by the adolescent period. These seizures, because they are arising from the Rolandic area, these seizures are more or less partial or focal seizures. We now use the term focal seizures more often. So they are focal seizures or partial seizures, usually without loss of consciousness. And then they are very infrequent seizures. They do not occur very frequently. So first infrequent seizures, then partial or focal seizures, and that too seizures where the consciousness is not lost. Then these seizures which disappear by the adolescents on their own. So that is why these are benign seizures. Many times if these seizures are infrequent, they do not require any treatment. Most of these seizures occur in the late night period, or seizures upon awakening. That's a very important way by which you can differentiate them from the adolescent seizures, which are called as juvenile myoclonic epilepsies. Although, as I told you, juvenile myoclonic epilepsies occurs in juvenile age groups, adolescents, and these seizures normally do not occur. Rolandic seizures do not occur in adolescents. But juvenile myoclonic epilepsies normally occur in the early morning hours, while most of the Rolandic seizures, they are known to occur during the late night period or upon awakening. So many of these seizures are missed also. They may be very benign, subtle, occur in the late night period, and many times they are missed also. So only when the seizures are very, very frequent, these Rolandic seizures, only then they need treatment. Otherwise, a treatment is not required for these seizures. And in case you do need to give treatment, then the treatment of choice usually will be carbamazepine, because of the fact that these seizures are these seizures are focal seizures. That is why Rolandic seizures should be treated with carbamazepine, which often has been the frontline drug for the treatment of the focal seizures. So for Rolandic seizures, you use carbamazepine. For juvenile myoclonic epilepsies, you use valproate. West syndrome, ACTH is the best first line drug. I did not know the fourth option, but ACTH, you should always link it with the West syndrome, or sometimes called as the infantile spasms. Or rather, infantile spasms are sometimes called as the West syndrome. This was the last question, which is a question about a 1-year-old child who comes to a primary health center for vaccination, and the child was previously vaccinated for DPT at 6 weeks. Now this is a case of missed vaccination. So it's not uncommon for us as pediatricians to get children who come to us with a missed dose of a vaccine. For example, one vaccine dose was given, scheduled at 6 weeks, then they forgot to get the vaccine at 10 and 14 weeks. And suppose they come at 1 year of age and tell us that one DPT vaccine was given at 6 weeks, then they forgot, and now they have come to you at 1 year of age. Now, DPT vaccine as such, what's the recommendation? It's a part of both the national immunization schedule and it's a part of the IP immunization schedule as well. So in the national immunization schedule, this DPT vaccine is often given with as a pentavalent vaccine, where it is given with the hepatitis B and Hep vaccine. So it's given at 6, 10 and 14 weeks, 16 to 24 months the first booster, and then 5 to 6 years the second booster. In the IP immunization schedule, the DPT vaccine is primarily given at 6, 10 and 14 weeks, with the first booster given at 16 to 18 months and the second booster given at 4 to 6 years. And then you get the from 10 years the small DPT vaccine with the small d, acellular pertussis and tetanus, which is given at 10 years of age. Now, most of these vaccines, they induce an immunological memory. And because of this fact that they induce an immune memory, once the antibody starts after a vaccine has been given, an immune memory is initiated. And because of that immune memory, it's never recommended to restart any vaccination schedule again. So even if one dose has been given and the child in between had missed 1 or 2 doses on the schedule times and comes to you at a later date, please complete the vaccination schedule by that date. Do not restart the vaccination schedule again. And it is very clearly given in the IP handbook on vaccination also that there is no need to restart a vaccine series regardless of the time that has elapsed between the individual doses. That's because of the fact that there is an immune memory present. Once antibodies form, there will be an immune memory. And because of that immune memory, there is no point of restarting the whole schedule. Just continue from where you have left. So if the first dose has already been given, start from the second dose, third dose, and always keep or maintain a 4 weeks gap between the 2 doses. Because if you try to bring those doses much nearer than the 4 weeks, then they might start interfering in the antibody response from one of the doses. So for example, if you have given a second dose at 10 weeks and if you give the third dose at 14 weeks, then it's fine. But if you give the third dose earlier than 14 weeks, the third dose may interfere with the antibody response to the second dose. So in cases like this, where a child was given the DPT vaccine at 6 weeks, the vaccine at 10 and 14 weeks was missed, and then the child has come to you at 1 year of age, you have to start from where the child had left. So you have to give the second dose of DPT and not restart the whole schedule again. More so, a DT vaccine will not be given at this point of time till the age of around 7 years. The DPT vaccine is usually recommended, and always give a capital D, diphtheria toxoid with a capital D, till the age of 7 years. But after the age of 7 years, you should give a DPT vaccine or a DT vaccine with a small d, which is lower dose of the diphtheria toxoid compared to the dose in the capital D vaccine, which is higher dose of the diphtheria toxoid. There have been cases of higher dose of diphtheria toxoid inducing immunogenic reactions when it was given in older children above 7 years of age. That's the reason why a DPT vaccine or DT vaccine which is given after the age of 7 years should always have lower dose of the diphtheria toxoid, about 2 locular dose, which is given by the abbreviation small d. Small d means lower dose of the diphtheria toxoid. When we say capital D, it means higher dose of the diphtheria toxoid, which is about 25 to 30 locular units of the diphtheria toxoid. So if you have any questions, you can ask me. Abbreviation small d. Small d means lower dose of it. So the question, Okay, so question, let us start reading the question. In neonatal resuscitation, they didn't ask the best parameter, they asked the initial most change. Initial most change. I have not understood this initial most change. If you can elaborate, I will ask you. What is the dose of what is the dose and route of vaccine? So if you are asking about the human papilloma virus vaccine, the dose is usually 0.5 ml and the route is intramuscular. These are intramuscular vaccines. It is given for girls also, for boys also. For girls, it is recommended as a vaccine for only children who are girls, to protect them against cervical cancers. Nonavalent human papilloma virus vaccine, as I told you, is a vaccine that is given in boys also to protect them against human papilloma virus induced cancers of the anus and cancers of the penis. So nonavalent vaccine is licensed for boys and girls, but human papilloma virus and bivalent and quadrivalent vaccines are only licensed for girls. And human papilloma virus vaccine is an intramuscular vaccine. It's a recombinant DNA vaccine and it is given to all children starting from the age of 9 years. So that answers the question. Is it affordable vaccine? Yes, it's an affordable vaccine, not a very costly vaccine. And all girls should definitely get this vaccine because of the protection it affords against the common strains of cervical cancers. 6, 11, 16, 18, which are one of the most common causes of cervical cancers. So even if the option is 1 dose, then the answer should be 1. If the option is 2 dose, answer should be 2. Yes, in case the option, as some students are saying, is 1 or 2 doses, then I think the best answer should be 1 or 2 doses. So there is a student who has said that the option was 1 or 2 doses. In case the option was 1 or 2 doses of the vaccine, 1 or 2 doses, then the answer should be 1 or 2 doses. So here let me correct it. In case the option was 1 or 2 doses, then according to me this should be the best answer, because this is what is being recommended by the Strategic Advisory Committee on Vaccination for WHO. 1 or 2 doses. So in case the option was 1 or 2 doses, then that should be the best answer. If the option is 1 dose, 2 dose, 3 dose, 4 dose, then the answer should be 2 doses. But if the fourth choice is 1 or 2 doses, then definitely this should be the best answer. So thank you for updating me. Okay, so Happiness Zone has written, why is he not reading the comments? I'm reading the comments. I only wanted to first tell you about the questions that I have got recalled from the students. Then I wanted to discuss about all your discussion points, right? So I would be reading the comments, but after having gone through all the questions. In the breast milk question, the baby was low birth weight and not preterm. Does that change the answer? No, according to me, that does not change the answer. Breast milk under any circumstance will always be the best. So donor breast milk would be advisable for preterm babies also, for low birth weight babies also. And any day will be superior to a formula milk. So that will not change the answer. The answer will remain as donor breast milk. Okay. Any other question that you have? So I am now going through these questions. Any question that you have, I hope you have all understood the questions that I wanted to convey. I am now reading your comments. So please do tell me if there is any other thing that you want to know. Anything that you have not understood from these questions, please feel free to ask. Regarding the contraindications of DPT, see, there have been many contraindications of DPT. and I've clearly told them in my app also, one of the most important and well-known contraindication of a DPT is any anaphylactic response to a previous dose. So suppose there was a previous dose of a DPT vaccine and that led to an anaphylactic response, then subsequent DPT vaccine should be avoided. So what should be the better option in such cases? The better option in such cases should be a DT vaccine, because the pertussis component has often been associated with the development of such anaphylactic responses. So if you really ask me, the best, and usually many people believe the only true contraindication of a DPT vaccine, then it should obviously be a previous reaction or an anaphylaxis to a previous dose. So if a first dose there is an anaphylaxis, do not give the second dose. Other contraindications, any encephalopathy that develops after giving a DPT vaccine, or any hypotensive or hyporesponsive episode which develops after a DPT vaccine. But please try to understand, or any seizures that develop immediately after a DPT vaccine. Those are other contraindications to a DPT vaccine. But please understand that one of the most acceptable contraindication for all DPT vaccines is always that the child should not be given a DPT vaccine if there has been an anaphylactic response with the previous dose of DPT vaccine. Also, many people believe that a progressive neurological disorder can be a contraindication to a DPT vaccine, progressive neurological disorder. And that's the reason why non-progressive neurological disorders such as cerebral palsies are not contraindications, and therefore DPT vaccines can be given in those conditions. If you go through my app, you will have this contraindications to the DPT vaccine, which are clearly mentioned in my app. Okay, so I hope I've answered that question. Any other question that you have, you can ask me, or you can send the comments in the comment section also. I would be more than happy to answer those questions. So I hope overall I have answered the queries. You have understood the questions and their answers. Any other options that you have you want to add, and you want to ask me if there will be a change in answer, if that option is added, you can please put in the comments box. I would be happy to answer that. For example, in this question, if the option was 1 or 2 doses, then definitely 1 or 2 doses will be the best answer, not 2 doses. Similarly, if there is any other change in the language or in the options of the question, please feel free to put that in the comment section. I would be happy to answer that. And overall, thank you very much. I hope this was a useful session for you, and I would be back then later on with your NEET PG recall questions also, once your NEET PG examinations are through. So all the best for your NEET PG exams, and I wish you all the best, and I hope to see you all successful for your NEET PG exams. Thank you very much, and goodbye.